Good day. Today we are going to discuss Advanced Cardiac Life Support or ACLS. The chain of survival is the structured emergency care system concept for treatment of cardiac arrest. It includes four components: early access, early CPR, early defibrillation, and early advanced care. If a community pre-hospital EMS can be activated promptly, reach the patient within 5 minutes of collapse, and deliver the first shock shortly thereafter, survival in excess of 15 to 20% can be expected, with recent reports of greater than 30% of survival. With delayed initiation of CPR, defibrillation, and access to the patient by the emergency services, the impact of advanced life support measures is small. Improved survival can only occur if structured emergency care systems allow trained providers to access the patient rapidly and deliver the appropriate treatment in a timely fashion. Delays in initiating the various links weaken the chain and adversely affect the next link, resulting in a decreased chance of a good outcome for the patient. Again, the concept of the chain of survival is composed of early access, early CPR, early defibrillation, and early advanced care. The basic life support assessments and interventions are often called the primary ABCD survey, and the advanced life support assessments and interventions are often called the secondary ABCD survey. An organized approach to resuscitation begins with the primary ABCD and blends smoothly with the secondary ABCD. These are summarized in the Universal ACLS algorithm. This method helps any ACLS provider remember the sequence of resuscitation actions and therefore be less likely to miss any of the vital steps in the care of the patient. The primary ABCD survey addresses the identification of cardiac arrest and performance of good quality CPR, including ventilation and defibrillation. For ventilation, bag valve masks deliver 21% oxygen if using room air, 60% oxygen when connected to an oxygen source with flow at 12 liters per minute, and 90 to 95% with a reservoir bag. Chest compressions need not be stopped to initiate or continue ventilation. The rescuer also needs to focus on providing good chest compressions with 30 compressions for every 2 ventilations, or a 30:2 ratio, with compression rate of more than or equal to 100 per minute, compression depth of at least 5 centimeters, and relaxation of pressure on the chest wall to allow unrestricted chest recoil. Feedback devices are available for the rescuer to provide improved standards of chest compressions. Mechanical CPR devices may also be used. The two most common types of mechanical CPR devices employed in clinical practice are the Lucas II with a piston attached to an active compression-decompression cup and the load distributing band autopulse. Defibrillator pads must be applied to the bare chest before application of the mechanical CPR devices. These devices allow provision of either 30:2 CPR or continuous chest compressions with interposed manual ventilations. The critical rhythms associated with cardiac arrest are ventricular fibrillation, pulseless ventricular tachycardia, asystole, and pulseless electrical activity. Defibrillation may be done with either an automated external defibrillator or AED or a manual defibrillator. Deliver shocks for ventricular fibrillation or pulseless ventricular tachycardia with minimal interruption of chest compressions only during actual shock delivery. Make sure that the position of the defibrillator pads does not interfere with monitoring leads. After delivery of the first shock, resume CPR immediately for up to about 2 minutes before reviewing the EKG monitor for a rhythm diagnosis. If a viable rhythm has returned, check for pulse and breathing. If breathing and pulse have returned, begin care for post-return of spontaneous circulation or ROSC management. If breathing is absent, continue rescue breathing with a bag valve mask at the rate of about 6 to 10 breaths per minute, and if pulse is not present, continue CPR and move to the secondary ABCD survey. Components of the secondary ABCD survey will be discussed later. The secondary ABCD survey includes endotracheal intubation or the placement of another airway adjunct, assessment of ventilatory status, gaining intravenous access, identifying EKG rhythms, delivering drugs to enhance circulation, and addressing the reasons for occurrence or persistence of cardiac arrest. While the secondary ABCDs are in progress, continue the basic resuscitative actions of the primary ABCDs. Usually, defibrillation pads are placed carefully left of the apex and to the right of the sternum just below the right clavicle, and they could also act as monitoring leads. Otherwise, true monitoring leads may be placed at the front of the right and left shoulders and over the left iliac crest. Such placement does not interfere with defibrillation or cardiac pacing procedures. Further management is based on the cardiac rhythm. Vascular access techniques would also be required in some cases. A large peripheral vein allows a rapid rate of fluid administration if needed. If unable to cannulate a peripheral vein, establish intraosseous access. Central venous lines take time to establish and because of the length of the cannula, cannot deliver fluids as rapidly as peripheral line, and every bolus dose of drugs requires flushing with at least 20 ml of normal saline. Central lines are useful for central venous pressure monitoring to guide fluid resuscitation and circulatory management. In cardiac arrest, circulation of blood grinds to a halt. With good quality CPR, one can expect to generate up to about 30% of normal cardiac output, which is just about what is required to supply vital organs such as the heart, brain, and kidneys. The reduced circulation is associated with a slower circulation time. Therefore, drugs given during a cardiac resuscitation are best administered via a proximal peripheral vein. Once drugs are given, flush the line with normal saline and continue CPR for at least 30 to 60 seconds before repeat external defibrillation so that the heart is optimally primed to respond. The optimal infusion fluid is normal saline and not dextrose, Ringer's lactate, or sodium bicarbonate. However, unless hypovolemia is a contributing factor to cardiac arrest, fluid infusion should be slow if at all necessary. Drug dosages are the same whether given by the intraosseous, IV, or central line routes. The endotracheal tube route is no longer recommended for drug administration because drug absorption is limited if the airway is filled with pulmonary edema fluid. So the universal ACLS algorithm is as follows for adult cardiac arrest. We begin with the primary ABCD survey and we focus on basic CPR and defibrillation. We check the patient's responsiveness, activate emergency response systems, and call for a defibrillator. We go and survey the airway and open the airway, breathing. We look, listen, and feel for breathing. Circulation involves checking for the pulse, starting CPR within 10 seconds, and defibrillation requires attachment of an EKG monitor or defibrillator. A special note is that for BLS, look, listen, and feel is de-emphasized, and it's more important to provide uninterrupted chest compressions. After the primary ABCD survey, we analyze and assess the rhythm. And if it is ventricular fibrillation or ventricular tachycardia, we attempt defibrillation once and, as necessary, then perform CPR for 1 to 2 minutes. Then we proceed to the secondary ABCD survey. The focus is on more advanced assessments and treatments. For the airway, we place an airway device as soon as possible. For breathing, we confirm airway device placement by examination with a confirmation device recommended. We secure the airway device and confirm effective oxygenation and ventilation. For circulation, we establish vascular access, identify and monitor the rhythm, and administer drugs as per rhythm and condition. And we also check the differential diagnosis, such as any identified reversible causes. If the patient has a non-VF or VT rhythm, we also perform CPR for 1 to 2 minutes but do not attempt defibrillation. Then we do a secondary ABCD survey again. Causes that are potentially reversible can be divided into 5 H's and 5 T's. Reversible causes are hypovolemia or hemorrhage, hypoxia, hydrogen ion or acidosis, hyper and hypokalemia, and other metabolic syndromes, and hypothermia. And the T's are tablets or trauma, such as drug overdoses or accidents, tamponade, especially cardiac, tension pneumothorax, thrombosis in the coronary aspect or ACS, and thrombosis in the pulmonary aspect or embolism. Drugs available for cardiac resuscitation and cardiac dysrhythmia management will be discussed now. And drugs are an adjunct in the management of cardiac arrest patients. Good CPR, ventilation, and early defibrillation are the cornerstones of management of cardiac arrest. The effectiveness of standard resuscitative drugs on ROSC and survival to hospital discharge has not been well demonstrated. However, consensus documents recommend the standard resuscitative drugs described below with the presumptive rationale that drugs help restart the heart and preserve coronary and cerebral circulation. Epinephrine is an endogenous catecholamine. It has an important role in cardiac arrest, although the evidence base for improved outcomes in humans is weak. Epinephrine seems to improve short-term survival. The primary beneficial effect appears to be peripheral vasoconstriction, which improves cerebral and coronary blood flow. Potential adverse effects include an increase in myocardial oxygen consumption and an increase in pulmonary shunting. The most common adverse reaction is tachycardia. Epinephrine may worsen myocardial ischemia and induce ventricular ectopy and VT. Epinephrine is used mainly to treat cardiac arrest from VF or pulseless VT unresponsive to the initial shock, asystole, PEA, and profoundly symptomatic bradycardia. The standard dose in cardiac arrest is 1.0 mg diluted to 10 ml or 10 ml of a 1:10,000 dilution given IV. Repeat if needed at 3 to 5 minute intervals. There is no maximum dose. Escalating doses at 2 to 5 milligrams IV every 3 to 5 minutes or high dose epinephrine have not resulted in increased long-term survival. For IV infusion in patients with cardiogenic shock or symptomatic bradycardia, the dose is 1 milligram in 500 ml normal saline beginning at 2 to 10 micrograms per minute, escalating as needed at 3 to 5 minute intervals. We do not add epinephrine to infusions that contain alkaline solutions because epinephrine has ineffective clinical activity in alkaline solutions. So before we continue discussing the drugs further, we look at the components of the secondary ABCD survey again. A is for securing the airway. We give endotracheal intubation or other supraglottic airways such as an LMA. For breathing or ventilation, we provide ventilation with a bag valve mask, oxygen, or mechanical ventilation. C is maintaining circulation. We continue CPR, provide defibrillation and cardioversion to correct life-threatening shockable rhythms, continuous EKG monitoring to monitor the circulation's rhythm and identify arrhythmias that need to be corrected, gain vascular access through an IV or IO line, provide drugs to help maintain circulation, and consider the use of ECMO. And for differential diagnosis, we determine why the patient is not responding to resuscitative efforts and look for correctable causes of collapse and provide necessary interventions. Specialized care after ROSC or return of spontaneous circulation includes therapeutic hypothermia, glycemic control, early goal-directed therapy, and percutaneous coronary interventions. More drugs that are used in advanced cardiac life support include amiodarone. It is generally considered a class 3 antiarrhythmic drug, but it possesses electrophysiologic characteristics of all four Vaughan Williams classes. It causes coronary and peripheral artery vasodilation. It is more effective than lidocaine in improving short-term survival. Its main use in cardiac arrest is for persistent VT or VF after defibrillation and epinephrine. It can also be used for hemodynamically stable VT, hemodynamically stable polymorphic VT, and hemodynamically stable wide complex tachycardia of uncertain origin. Amiodarone is also used for pharmacologic conversion of atrial fibrillation, control of rapid ventricular rate in pre-excitation supraventricular dysrhythmias, and as an adjunct to electrical cardioversion of refractory paroxysmal supraventricular tachycardia or atrial tachycardia. For pulseless VT or VF, the dose is a bolus of 300 mg IV followed by a 20 ml flush with 5% dextrose in water or saline. We give another 150 mg bolus if there is no response to the first dose. For stable ventricular and supraventricular dysrhythmias, we administer IV amiodarone for 150 mg over 10 to 15 minutes not to exceed 30 milligrams per minute, followed by a maintenance infusion of 1 milligram per minute for 6 hours and then 0.5 milligrams per minute for the next 18 hours. Infusions exceeding 2 hours should be administered in glass or polyolefin bottles because the drug precipitates in plastic tubing. Hypotension and bradycardia are the most common unwanted effects. These may be addressed by slowing the infusion rate, giving an IV fluid challenge, or using pressors or positive chronotropic agents. Occasionally, temporary pacing for refractory bradycardia from amiodarone may be required, especially if other measures are ineffective. Lidocaine or lignocaine is a class 1 antiarrhythmic drug. It reduces automaticity, suppresses ventricular ectopy, and is used for hemodynamically stable VT and refractory VF or pulseless VT. Lidocaine is a second choice drug after amiodarone or is used if amiodarone is not available. In cardiac arrest, the dose is an IV bolus of 1 to 1.5 milligrams per kilogram body weight. Give a second dose of 0.5 to 0.75 milligrams per kilogram if the rhythm persists. Upon restoration of spontaneous circulation, give lidocaine as an infusion at a rate of 1 to 4 milligrams per minute. If dysrhythmia reappears during the infusion of lidocaine, give a bolus of 0.5 milligrams per kilogram and increase the infusion rate to 4 milligrams per minute. Toxicity may occur with doses exceeding 3 milligrams per kilogram body weight bolus or in patients with liver disease since the drug is hepatically metabolized. Symptoms include neurologic changes such as drowsiness, disorientation, reduced hearing ability, perioral paresthesia, muscle tremors, and seizures. Myocardial depression and circulatory depression are also features of toxicity, and these may be illustrated by widening QRS complexes and failing blood pressures. In patients with known impaired liver function or patients older than 70 years old, give the same recommended bolus doses but decrease the normal infusion rate by 50%. Magnesium is a cofactor in numerous enzymatic reactions. It is essential for the function of the sodium-potassium ADPase pump. Magnesium deficiency may be associated with cardiac arrhythmias, sudden death, and precipitation of VF. Magnesium is used to treat hypomagnesemia with or without dysrhythmias. Magnesium is the initial treatment for torsade de poids and dysrhythmia secondary to hypomagnesemia, cardiac arrest from QTc prolongation, or cardiac glycoside toxicity. For patients in VF or pulseless VT due to the above conditions, give 1 to 2 grams in 10 ml of 5% dextrose in water IV over 1 minute. Magnesium provides no benefit for routine use in cardiac arrest. For patients with a pulse, the dose is 1 to 4 grams in 50 ml 5% dextrose in water over 60 minutes. Adverse reactions include flushing, sweating, mild bradycardia, hypotension, asystole with circulatory collapse with too rapid of an administration, and respiratory depression. Hypermagnesemia may produce depressed reflexes, flaccid paralysis, diarrhea, respiratory depression, and circulatory collapse. Other drugs in cardiac arrest include atropine, calcium, sodium bicarbonate, and vasopressin. So, atropine is a parasympatholytic agent that enhances sinus node automaticity and atrioventricular conduction by direct vagolytic action. It is not recommended for pulseless electrical activity or for treatment of cardiac arrest. It is indicated for symptomatic bradycardia. The dose is zero point 0.5 or zero point 0.6 milligrams IV and may be repeated at 5 to 10 minute intervals up to a maximum of 0.04 milligrams per kilogram body weight. Atropine may induce tachycardia or premature ventricular contractions and cause worsening of myocardial ischemia. Symptoms of overdosage include tachycardia, delirium, coma, flushed and hot skin, ataxia, and blurred vision. Administration of low doses less than 0.5 milligrams IV may produce paradoxical bradycardia and precipitate VF. Calcium is given during resuscitation only for cardiac arrest from hyperkalemia, hypocalcemia, or calcium channel blocker overdose. Calcium is not recommended for routine administration for VF, pulseless VT, or PEA. The dose of calcium chloride is 0.2 ml per kilogram of 10% calcium chloride given as a slow IV bolus. The use of sodium bicarbonate during cardiac arrest was advocated in the past to treat presumptive acidosis because severe acidosis decreases myocardial contractility, but routine use during cardiac arrest is no longer recommended due to a number of potential adverse effects. Sodium bicarbonate causes hypernatremia, hyperosmolality, and alkalosis, which in turn induces a left shift of the oxyhemoglobin dissociation curve, and IV sodium bicarbonate produces carbon dioxide, resulting in hypercarbia unless ventilation is increased. It does not appear to improve defibrillation success. It may be given in cardiac arrest from hyperkalemia or cyclic antidepressant overdose. It is also acceptable and possibly helpful for intubated patients with a long arrest interval until ROSC and with persistent severe metabolic acidosis. The dose is 1 to 1.5 mEq per kilogram IV bolus, followed by 0.75 mEq per kilogram every 10 to 15 minutes as needed. If continuous infusion of sodium bicarbonate is used, we check pH to guide therapy. Vasopressin, also called antidiuretic hormone, is a naturally occurring neurohypophyseal peptide hormone synthesized in the hypothalamus and stored in the pituitary gland. It increases water absorption in the nephron and increases peripheral vascular resistance. Vasopressin levels elevate during cardiac arrest, and this observation led to investigation of its role in resuscitation. Vasopressin has a longer duration of action and in laboratory studies maintains coronary perfusion pressure, myocardial blood flow, and cerebral blood flow better than epinephrine. However, most studies do not show superiority of vasopressin over epinephrine. Vasopressin as a first-line agent in cardiac arrest with a 40 mg dose does not improve long-term survival when compared to epinephrine, although vasopressin may improve short-term survival in patients with prolonged cardiac arrest. Combining vasopressin 40 mg with epinephrine does not appear to improve outcomes. The algorithmic approach to cardiac arrest management allows a structured decision-making process when managing cardiac arrest victims. The cardiac arrest rhythms discussed here are pulseless VT or VF, and asystole and PEA. So for ventricular fibrillation or pulseless ventricular tachycardia, once VF or pulseless VT is diagnosed, we prepare for electrical conversion while CPR is in process. If ROSC does not occur after the first shock, move to the mega VF approach, which will be discussed later. Continue CPR for 1 to 2 minutes, followed by rhythm analysis, and if VF persists or recurs, deliver electrical shocks, usually biphasic, beginning usually at 150 joules and escalating, if needed, to 360 joules. For monophasic defibrillators, begin at 360 joules. After delivery of shock, follow with CPR again for 1 to 2 minutes before rhythm analysis. Maintain good quality CPR for optimal coronary and vital organ perfusion. Parallel to the CPR analysis, shock, CPR analysis, shock, CPR cycle, begin secondary ABCDs and give drugs that may help to lower defibrillation thresholds, such as epinephrine, amiodarone, or lidocaine. Any or all of these drugs may be administered in any combination and repeated at roughly 3 to 5 minute intervals. After administration of any of these drugs, provide at least 30 to 60 seconds of effective CPR to allow the injected drug to reach the central circulation before the next shock. Continue the resuscitation cycle for as long as the rhythm remains as VF or pulseless VT. For asystole or PEA, or a condition in which cardiac contractions are absent in the presence of coordinated electrical activity, continue CPR and institute the secondary ABCDs. We give drugs to enhance the chances of ROSC, and epinephrine 1.0 mg as a bolus dose in 10 ml is the drug of choice. Vasopressin alone or in combination with epinephrine is no more effective than epinephrine alone. Repeat epinephrine as needed in 3 to 5 minute intervals. We consider other possible causes of asystole or PEA and identify and correct them. It is currently assumed that narrow complex PEA could be the result of mechanical problems such as cardiac tamponade, pneumothorax, mechanical hyperinflation, pulmonary embolism, or myocardial rupture. Point-of-care ultrasound and assessment of the clinical scenario can direct specific treatment. Wide complex PEA, on the other hand, can result from a metabolic problem such as hyperkalemia, drug toxicity such as sodium channel blocker toxicity, or cardiac ischemia, and left ventricular failure should be treated as appropriate. Survival is low if patients in asystole do not achieve ROSC in the field or convert to a shockable rhythm. In every resuscitation, it is useful to identify important causes of cardiac arrest and reasons for lack of response to standard resuscitation algorithms. Causes can be grouped as the 5 H's and 5 T's as mentioned earlier. And for the purposes of recap, the 5 H's and 5 T's are hypovolemia or hemorrhage, hypoxia, hydrogen ion or acidosis, hypo or hyperkalemia and hypothermia, and trauma plus tablets such as in overdose, cardiac tamponade, coronary thrombosis, tension pneumothorax, and thrombosis in pulmonary embolism. A history of fluid or blood loss may be available. Rectal examination can identify massive lower gastrointestinal bleeding, nasogastric intubation can identify massive upper gastrointestinal bleeding, and bedside fast can diagnose massive intraperitoneal bleeding. Treat with fluids and blood products. Hypoxia occurs with a lack of oxygen and alveolar ventilation. Make sure that the airway is adjunctly placed correctly. Check breath sounds at intervals to ensure that the endotracheal tube has not slipped out of the trachea or to identify pneumothorax. Verify the source of oxygen, such as an oxygen cylinder or the piped oxygen supply. The acidosis of cardiac arrest is a combination of respiratory and metabolic acidosis. Respiratory acidosis is addressed by early endotracheal intubation and alveolar ventilation. Metabolic acidosis can be somewhat addressed by good quality CPR. Sodium bicarbonate is administered for a severe metabolic acidosis from prolonged or poor initial resuscitation at a dose of 1 to 1.5 mg per kilogram. Half the initial dose can be re-administered after 10 to 15 minutes depending on pH. We also suspect hyperkalemia in patients on hemodialysis or peritoneal dialysis, and other metabolic disorders are extremely difficult to confidently identify in cardiac arrest. If hyperkalemia is suspected, administer calcium chloride, sodium bicarbonate, insulin, and glucose. Treat hyperkalemia from suspected digitalis toxicity with IV magnesium sulfate or digoxin-specific Fab fragments. We also treat hypothermia with gradual rewarming with blankets and warm IV fluids. If there is no recovery of consciousness in the hypothermic patient following ROSC, maintain a body core temperature of 33 degrees Celsius until further assessment and decisions can be made. For tablets or drug overdose, it is rarely identified as a cause of cardiac arrest during the resuscitation process. In the event of antidepressant overdose, we administer IV sodium bicarbonate. Lipid emulsion infusion may be useful in cardiac arrest associated with cyclic antidepressants or local anesthetics. Cardiac tamponade is best identified during resuscitation by bedside transthoracic ultrasound. This requires brief interruption of chest compressions. Treatment of tamponade causing cardiac arrest is bedside pericardiocentesis. We suspect tension pneumothorax during cardiac resuscitation if breath sounds are unequal on chest auscultation after verifying correct endotracheal tube placement. Treatment is immediate needle decompression. Acute coronary thrombosis or acute myocardial infarction is one of the most common causes of cardiac arrest. Risk factors are a history of coronary artery disease and an initial rhythm of VF or VT. Cardiac catheterization after resuscitation is an underused procedure. A 12-lead EKG in the immediate post-cardiac arrest state can identify an ST elevation, acute myocardial infarction, advocate for cardiac catheterization, and we also do percutaneous coronary revascularization if available and appropriate after ROSC. A 12-lead ECG in the immediate post-cardiac arrest state can identify an ST elevation, acute myocardial infarction, and allow arrangements for immediate coronary angiography. Myocardial and neurologic function can improve after percutaneous coronary intervention following cardiac arrest. Thus, after ROSC, especially in the face of post-ROSC EKG evidence of acute myocardial infarction, advocate for cardiac catheterization and percutaneous coronary revascularization if available and appropriate. Pulmonary embolism causing cardiac arrest requires fibrinolysis or embolectomy. However, the diagnosis is rarely made at the time of collapse, and even then, most systems are not geared to make such prompt diagnosis and initiate the necessary procedures and embolectomy. Fibrinolytic agents could be considered during a cardiac arrest from suspected pulmonary embolism on a case-by-case basis. Factors suggestive of pulmonary embolism causing cardiac arrest include 2 of 3 signs or symptoms such as pre-arrest respiratory distress, altered mental status or shock, arrest witnessed by a physician or emergency medical technician, and PEA as the first or primary arrest rhythm. After ROSC, many factors affect survival: anoxic brain injury, post-cardiac arrest myocardial dysfunction, the systemic reperfusion response, and the cause of cardiac arrest. Anoxic brain injury results in disturbance of cerebral microvascular hemostasis and manifests as coma, seizures, myoclonus, and varying degrees of neurocognitive dysfunction, including brain death. Post-cardiac arrest myocardial dysfunction results from myocardial stunning with cardiac hypokinesis and a low left ventricular ejection fraction. Clinical manifestations include tachycardia and elevated left ventricular and diastolic pressures, progressing to hypotension and reduced cardiac output. The systemic ischemia reperfusion response consists of inflammation, endothelial activation, and disturbed vasoregulation with generalized activation of immunologic and coagulation pathways, causing increased risk of multiple organ failure and infection. Clinical manifestations of the systemic ischemia reperfusion response include impaired oxygen delivery and utilization and increased susceptibility to infection. Hyperoxia during the early phase of reperfusion after ROSC harms post-ischemic neurons and increases brain lipid peroxidation. After ROSC, adjust the rate of ventilation and tidal volume to maintain arterial oxyhemoglobin saturation at 94 to 98%. Hyperventilation is not recommended because it can increase intrathoracic pressures and decrease venous return and cardiac output. In addition, hypocarbia resulting from hyperventilation decreases cerebral blood flow and aggravates anoxic brain damage. We also obtain a 12-lead EKG after ROSC and repeat at 8 hours or as needed. We administer IV fluids and drugs to optimize blood pressure, cardiac output, and urine output. The target for blood pressure is a mean arterial pressure of 65 to 100 millimeters mercury, and the target for blood oxygenation is an SCVO2 of more than or equal to 70%. Pharmaceutical agents to support the circulation include epinephrine, norepinephrine, dopamine, dobutamine, nitroglycerin, and esmolol. We obtain an echocardiogram at 24 hours after ROSC to detect regional wall motion abnormalities and determine ejection fraction. Brain cooling decreases cerebral oxygen demand, reduces cellular effects of reperfusion, and decreases the production of reactive oxide radicals. Targeted temperature management with cooling to 32 to 36 degrees Celsius with a temperature goal controversial during the first 24 hours after ROSC improves survival and neurologic recovery in patients who remain comatose soon after ROSC. Hyperpyrexia during the first 48 hours is usually associated with a lower chance of optimal neurologic recovery. Post-ROSC hyperglycemia is associated with increased mortality and worse neurologic outcomes. Hypoglycemia, similarly, is also associated with poor outcomes in critically ill patients. Maintain blood sugar levels between 100 and 180 milligrams per deciliter. Features of brain injury after ROSC include coma, seizures, myoclonus, and various degrees of neurocognitive dysfunction ranging from memory deficits to a persistent vegetative state and finally brain death. We treat seizures promptly. The neurologic prognosis in the majority of comatose cardiac arrest survivors undergoing therapeutic hypothermia cannot be reliably predicted in the emergency room. Our reference is Tintinalli's Emergency Medicine. Thank you very much.